Okay, so we'll make a start. So hello and welcome everybody. I'm Annette.breen, one of the lead nurses with the East Genomic Medical Services Alliance, and welcome to our bite-sized genomics lunch and learn. It's a small select group today because some people who are going to join are being called away to clinical situations, but it will be available afterwards to watch on catch up. And just to let everybody know, I'm recording the meeting, so I hope that's okay with everybody. So I'm going to do a short presentation about consent and confidentiality in genomics to pave the way for Caroline Hoad and Shelby Mathlin, who are paediatric genomic nurse practitioners at Cambridge University Hospital based at Addenbrooke's, and to talk about how they're bringing a little bit about the transformation project they're working on, and why and how they're bringing consent conversations into pathways with families and improving care pathways. So I'll just start off. So when we're thinking about consent and confidentiality, obviously it's thoroughly embedded in our routine healthcare practice. I think every intervention that we do with a patient requires their consent and to allow them to make an informed choice about whether they want to go ahead or not. Sometimes consent is, oh, you're going to have a blood test, the patient will just put their arm out. But with some more complicated things, like if a patient's having a surgical procedure or a genomic test, it's a little bit more complex. And consent for genomic testing just builds on existing practice for consent. But in genomics, there are a few additional complexities to consider. So, got the wider family. So, when an individual has a genomic test, the information, the results are personal to them. However, family members could be impacted by the test results. So they've got shared genetic information, obviously, because they're related. And so that means they might be at risk of developing the condition or not. Or they could be carers for their relative. So they might not be at risk of the condition, but they might be caring for their relative, and they might find out information about the implications of the condition from the genomic test result. Can also get unexpected test results, which are quite difficult to cover in a consent conversation. So sometimes non-paternity arises, or unexpected medical information. And sometimes during the consent conversation, a couple, it might become, a partner may disclose that they're not the biological father of the child, which might be new information to, the mother might disclose that the father, who the man sitting with her, isn't the child's biological father, which, can be quite difficult during those conversations. And then, we can make the assumption that all families are sort of happy to share their genomic test results with their families, but they're not. And sometimes people only want to share with part of their family. And then we've got quite a large scope of genomic information, so can be used for early diagnosis, opening up more treatment possibilities, more precise diagnosis, giving a clear identification of an underlying cause of disease. More precise diagnosis allows better treatments to be selected, so precision medicine, because we'll all have examples in our practice of the same medicine is administered to a large group of patients. Some respond positively, have no side effects. Some respond positively, have horrible side effects. Some don't respond, have no side effects, and some don't respond to the medicine and have horrible side effects. So getting that precision medicine is important. And so fewer adverse reactions to medicine. And then looking at eligibility for clinical trials, and identifying predisposition markers, which we'll talk about a little bit more. So genomic testing doesn't always provide a neat, clear-cut answer. So sometimes the results can be positive, which is a gene alteration is identified. And I think, as in common with a lot of test results, positive makes it sound like it's good news, so it may or may not be good news for an individual. Or negative, a gene alteration isn't identified, so it doesn't change the patient's diagnosis or their symptoms, but it doesn't rule out a genomic condition, and might need to go back in the future to look at other genes, which may not be possible now. And then the other result that is possible is an uncertain result. So might be a different gene alteration is found and the significance isn't known currently, and it's not known if this could explain the patient's condition, and testing can't be offered to other family members. And then also genomic tests are potentially predictive. So some of the tests are to confirm or find a diagnosis in an individual, and some tests are predictive. So they'll give an indication of the risk or chance that the individual has of developing a certain condition. And interpretation of risk is very individual. So an individual may be given a very objective low risk figure, so their chance of developing a condition might be 1 in several thousand, but they might interpret it as high and vice versa. And then I think also individuals are less able to assess risk when they're faced with strong positive or negative emotions, which when obviously dealing with, somebody being at risk of a potentially nasty inherited condition, there's going to usually be strong emotions involved. And then there's data storage and sharing protocols to consider. So genomics test samples are stored, and digital storage of genomic data, as in common with other healthcare information, is also becoming standard. So this means that the data can be reviewed if new information becomes available. And then this might mean in the future that further testing is possible. So if an individual's had a negative or non-informative result, their stored sample can be used. And obviously the person would have to be consented for that. Can't just, the NHS can't just test samples as they wish. It has to be with the individual's full consent. And then also the samples used, if there was a positive result and the other family members wish to have a test, the individual sample can be used to interpret the family members' results more accurately and informatively. And then to help us along with that, and Shelby and Caroline will be talking about, I'm sure, there's a record of discussion form which NHS, which Genomics Education have produced, which is available online, and that goes through, obviously inserting the patient demographics at the top, and it goes through each of these different areas to ensure that they're covered in the discussion and that the discussion is appropriate, the appropriate level for the patient to comprehend. And there's just a few more resources for you to find out, if you want to read more about consent and confidentiality.
Hi everyone. So myself and Shelby are Paediatric Genomic nurse specialists at Adam Brooks Hospital in Cambridge. So we're just going to be talking about the pilot project that we're currently doing here. And just a little bit of background, there are obviously a lot of other projects, but the main two ones that kind of paved the way for our for our pilot, the 100,000 Genomes project, which was launched in 2012. The recruitment for that was completed in 2018, and the first diagnosis of children was returned in 2016. There's still a lot of ongoing analysis and research for it, but so far there's over 70 research projects looking at rare disease in children. And it also established the National Genomic Research Library. The other project, which was Cambridge-based, was the Next Generation project, which happened in 2019. And that looked at the rapid diagnosis via trio whole genome sequencing. And that took around just less than 200 family samples from NICU and PICU. And that found that 1 in 4 babies had a genetic condition, and the majority of those cases it affected the treatment that the baby had in the end. And it also showed that in neurology, 40% of those children also had a diagnosis. So that was a very important project, and one that kind of led to us doing this pilot. So this pilot is one of 7 national transformation projects for nursing and midwifery. It's a 1-year study to embed genomic practitioners into neonatal, paediatric intensive care and paediatric neurology. There's also a parallel project going on in Nottingham using genetic counsellors, and also another one in Leicester using genomic practitioners. The focus for our pilot is on whole genome sequencing, and it's looking mainly at the R14 test from the directory, which is the rapid test for an acutely unwell child, which where they would likely have a monogenic disorder, so a disease coming from a single gene variant, and the aim is to get a rapid diagnosis. So it's around 3 weeks at the moment to inform decisions.
So, as Caroline said, those projects kind of paved the way for a rationale behind kind of having sort of dedicated teams to kind of consent for testing. So one of the main aims of our role is a better coordination of testing between clinical genetics and paediatrics. Historically, it's generally done by clinicians. So, for example, in outpatients, it would be done by clinicians during the outpatient appointments. So this would obviously be very time-consuming for them. It would also often cause delays in their clinics, which wasn't very good, for patients or for the staff. As a result of the time constraints, sometimes the consent conversations would be sort of very quick, and obviously whole genome sequencing is quite an extensive thing. It's quite an extensive test for families to have. There's a lot to consider for them, so they need to be given all, have the time to be given all the information and time to have that to make that decision for what's best for them and their family. So another aim is to sort of reduce delays. So especially for R14s, they're predominantly on NICU and PICU. So to allow that time for once we are informed of these patients, we prioritise the R14s. We sort of triage them and obviously prioritise the R14s. So then we come up. Majority of the time, we'll come up on the same day, meet with the family, have the consent conversation with them, arrange samples, and aim to get the sort of the testing process kind of ready to send out to Exeter within a few days. Another one of our aims is to overall embed genomics into paediatric patient care pathways. Obviously, whole genome sequencing isn't a brand new thing, but it's becoming a much bigger part of the NHS. So part of our role is to help create pathways and embed it more firmly into paediatric services and at Addenbrooke's, and see how we can slot it in to make pathways and clinical services a lot smoother for patients and for clinicians. and then increased support and point of contact for families in the interim from consenting to results. Obviously, again, whole genome sequencing is quite expensive. There's a lot of families to think about, and it's quite a long conversation sometimes. So again, it's given that family, we give the families the contact details, and it means that whilst they're waiting for results, they can contact us with any questions they have about testing, anything they may have forgotten, or to clarify anything, to make sure that they have made the right decision for them. So because our role is very new, when we started, we had to kind of start from scratch, and obviously there aren't paediatric genomic specialist nurses kind of anywhere, so it's been a big learning curve to kind of pinpoint what sort of training and education other nurses in our roles in the future may benefit from. So when we first started in August, we were directed to the Health Education England Genomics 101 programme, which is just really good for a baseline understanding of genetics, whole genome sequencing, as well as taking family history and the consent conversation. It's a very good baseline understanding. It's just an online e-learning program, which is really helpful. We also did the EastGLH learning portal for patient choice, discussing whole genome sequencing with patients. So that was to be able to do the consent conversation with families, which was obviously much needed information, so that we can make sure we were giving the right information to patients. In September, we did the genomic and counselling skills for nurses and healthcare professionals. So we did one module for the PG Cert programme, which was funded by Health Education England, and that lasted 6 months. So yeah, it took 6 months, and again, that was really good for kind of giving a baseline understanding for genetics and whole genome sequencing generally and in the NHS. And we worked with a lot of different specialist nurses from around the UK and cancer nurses, and it was really interesting to see how genomics and whole genome sequencing is fitting into so many different areas across the country. And we also we regularly check the East Paediatric Genomics Forum, which happens monthly, and they cover different topics every month about, consent conversations, difficult conversations, new test updates, which is really handy when we're discussing testing with patients.
Just to quickly touch on our main roles. So as Shelby said previously, we're looking at the pathway development, particularly for intensive care and outpatient settings. So we've developed 2 separate pathways to ensure that we get involved at the right time. And another role is that we tried to ensure fully informed consent for families using the record of discussion, which Annette showed you earlier. So we kind of have the time to be able to go through the form with families and cover any questions that they might have. The consent is in intensive care, it's often face-to-face on the ward with the families, or ideally in a separate room if possible. And when we do the consenting clinics, it can often be remotely via a video call, which can come with its challenges as well. We also arrange the parental samples. So when you're looking at the trio whole genome, you ideally would want the child and both parent samples. So it's just kind of trying to sort out the logistics of those as well. And then we regularly are in contact with the genomic laboratories to ensure that the samples have got there, and the record of discussions, they can see them. And then we thought we'd just quickly look at some of the challenges that we kind of face, particularly in intensive care with consenting. Obviously, it's difficult. It's different to a clinic scenario where you might have an hour with the families. You often kind of go in difficult circumstances, so you have to make sure that you're trying to go at the right time, or a time that's going to be easier for the families to kind of be able to understand the information and take in the information that you're going to be talking to them about, because it's often obviously quite complex genetic things that you're talking about, and things that will potentially affect not just the child but also them as the parents as well. Also important that we manage their expectations. So often families will want this test so that they will get a diagnosis and they'll know exactly what's going on with their child. But often we also have to explain that there might not be a result from this testing, so that can kind of produce some uncertainty for families still. And then receiving a confirmed diagnosis obviously can lead to some potentially difficult situations, such as kind of palliative care decisions and things like that. And then just finally, there's a couple of quite really good kind of further guidance specifically to paediatrics. So the Royal College of Physicians and Genomic Medicine Society have released the genetic testing in childhood guidance, which is quite a lengthy document. I think it's about 60 pages, but it really covers the legal and ethical considerations for testing in children really well, including whole genome sequencing. And then the Genomics education programme have literally just released the G notes for paediatrics, which is, yeah, it looks amazing. I have yet to look through it all, but that's just released, so that will be very, very useful. Thank you for listening. Has anyone got any questions at all?
Hi, sorry, it's Lydia from Birmingham Children's. Hi, it's fantastic. I'm so excited to find that there are other people doing the same stuff that we're doing. But I did the genomic counselling with UOB last year. I finished in July last year, and it's really made a big difference. But the way we do it slightly different is I have a standalone clinic. Once a week, I have a standalone clinic, and that really helps in getting parents to have the opportunity to, speak their minds. There's a lot of tears, hugging and crying, because that's the one opportunity they have. And I really make sure I give them an hour for each family so that they can air whatever. And we go through, expectations, the future, the fears, and all sorts of, we have the opportunity to do that. And it really has made a big difference having that standalone. The R14s, I help with our postgraduate doctors. But, if the patient is on the ward, then I can do the paperwork for them and then help with that. But because it's an urgent, R14s, I normally expect, the junior doctors to do it. But like I said, if I'm available, I do the packs for them. I do the, the forms are ready for them. But it's really, yeah. I'm excited about this. I really am excited. Yeah.
So Lydia,
yes.
Lydia, can I say? So you see the families in a separate location, not on the unit.
No. We actually have a clinical appointment.
Oh, so you make.
Yeah. So we're doing it as a standalone clinic where they're booked in advance, and they come in and we give each family an hour.
Ah.
Yeah, and that works better because, as you know, if they're in the clinic with the doctor, there's too many things going on. On the ward, I only do one when it's requested because they're around and they live far away from Birmingham. But everybody else, they come in as a regular clinic appointment.
Oh, Naomi's got a question.
Mm-hmm. Somebody.
Yeah, we're both nurses at Nottingham Children's Hospital, and Sarah's just been up to Birmingham actually to spend some time with Lydia.
Hi, Lydia.
We're trying to start some kind of service here within the neurology service, and we just wondered whether or not we might be able to touch base with you outside of this meeting, Shelby and Caroline, as well, just because there's quite a lot of stuff that needs unpacking, but our neurology doctors are really keen for us to do that. So is that all right if we just...
Yeah, of course.
Yeah. Because we want to discuss like, and the other question we had was sort of training and stuff around it, because obviously doing all the consent and everything, obviously there'll need to be some kind of, so we've been given modules to do, but it'd be really helpful to have a bit more in depth of what is really necessary and needed.
Yeah, absolutely. Yeah.
Thank you. That's great.
I think the HEE, I don't know about where you are, but at Birmingham, they are desperate for people to do the course because the funding is only dependent on somebody turning up. So I've had one of our gastro consultants has just been on it. So we're trying very hard to encourage as many people to utilize the funding, because if people don't come forward to do it, they lose the funding. So if you have people who want it, the funding is there. We just need people to go and do it.
Mary's got her hand up.
Oh, there, I'm muted. Hello, I'm Mari. I'm from the Oxford Clinical Genetics team. So at the moment, well, my background is nursing, but I'm actually a senior genomic practitioner here. And I'm just curious to know whether you're aware of genomic practitioners and what the overlap is between your roles and genomic practitioner roles.
So a few months ago, I think we had we've had a couple of new genomic practitioners start with us. I think they're the first to have started at Addenbrooke's. So from our understanding, because when they first started, we were a bit kind of, I think we were all a bit unsure about how they'd kind of interlink with us, or if they did at all, or kind of what the relationship was going to be. So my understanding, at least, I don't know, it might be different from Caroline. So my understanding is that because we thought that they'd so they're kind of more lab-based. So our understanding is that they're going to be more involved with that kind of side of whole genome testing. Is that what you understood, Caroline? Or?
Yes, and I think initially they've been looking at incomplete tests and trying to catch up with families, you know, where they maybe haven't got all the samples or all of the record of discussions. They're kind of looking at historical tests, but yeah, it's quite a new role for them. So I think they're still working on exactly what they'll be doing, but yeah, we do see them occasionally.
Yeah, so it's not as interchangeable with our role as we sort of thought it would be, because we thought we'd almost be tripping over each other's feet and who's kind of working with which patients. But yeah, so it does seem relatively separate, and like Caroline said, they're kind of more sort of basing themselves with historical tests and chasing families samples that way, whereas we're kind of on the wards and in clinics with patients, if that makes sense. So there's still a bit of clarity that's needed, but because it's still a new role for us here and for the genomic practitioners here, there's still a bit of clarity that kind of needs ironing out over exactly what sort of the specification is.
So it sounds like, Caroline and Shelby, you're dealing with sort of new patients, new children, whereas the practitioners, it might be children who haven't got a diagnosis. They might have had a DNA stored in the past, and they're sort of looking through those records. Would that be? Yeah. Which is, again, that's where one of the complexities of genomic testing consent comes in, sort of doing testing on stored samples. That's my understanding. I don't know if that's correct or.
Yeah, no, I think that's right. Yeah.
Oh.
We're still working on it, but that's sort of our understanding so far.
Oh, that's great.
Brilliant, thank you. I suppose the roles are just slightly different in your patch compared to the Central and South patch, where the genomic practitioners actually do both the records of discussion and consenting. And interestingly, I've not heard of a lot of genomic nurse specialists from our patch as well. So that's good to know. Thanks.
Oh, that is good. And I know, Caroline and Shelby, you're hoping to get involved in the sort of whole pathway. So when families are getting results, you're hoping to become involved in that, because obviously genomic testing can have quite a long time frame until the results are available.
Yeah.
So that's great. So that's been great. So thank you so much for your time, Caroline and Shelby, and thank you to everybody for joining us. And if we will send out a survey, so you could fill it in. But if you've got any comments that you want to put in the chat, any feedback for Caroline and Shelby, I'm sure they'd be very grateful because they can use it for their revalidation. So thank you very much, everybody, and I hope you have a good afternoon and get to enjoy some of the lovely weather either later today or later this week. Okay, thank you.
Thank you.
Bye.